We're at the 7th Conference on Pathogenesis and Treatment and Prevention, and it is being held in Kuala Lumpur, and we're here with one of the past presidents of the conference, the IAS, and that is Julio Montaner, who is with the Center of Excellence in Vancouver, BC, and who will also co-chair the next similar meeting in 2 years.
2015.
2015, yeah. So we really appreciate you taking the time to spend it with us. And the first thing we always talk about, because we want to make sure it's covered well, is treatment as prevention. Because we've talked about that over and over again. But it always needs to we need to come back to it and resound where we are and where we need to go.
You know, one day we need to do a little bit of a vignette of the history of our discussions over the years, because I'm sure it's going to be very interesting how the discussion has evolved. And truly, that sort of is a segue to say, in my opinion, Kuala Lumpur could be the tipping point for us to move treatment and prevention forward globally. As I was telling some of my colleagues, I could spend hours having a discussion, academic discussion, about whether I would have worded the guidelines a little bit different here and there, and I would have liked to include this and that, and more of this and less of that, or whatever. Some of my more sort of orthodox, sort of committed treatment prevention colleagues, they say, well, we need to push for test and treat. And my message is simple. I'm a very practical man. That discussion is very interesting, but what the WHO guidelines have done is have taken a huge step forward that have now opened the door for us to revisit eligibility for antiretroviral therapy in the lower and middle-income countries to the tune of not just 15 million people, but 26 million people. And to be perfectly honest with you, if you interpret serodiscordant couples a little bit more liberal than others, there is no limit to who we can actually offer antiretroviral therapy. If you consider that today we have 9 to 10 million people on antiretroviral therapy, and that we want to effectively approach all of those individuals and say, this is your opportunity to be on treatment for your benefit, and secondarily, to stop this epidemic altogether. The good that can come out of Kuala Lumpur is incredible. So, rather than spending time discussing what are we going to call the strategy, who is going to take credit for it, whether the hepatitis C people are included or not, doesn't really matter. The important thing is that we have now moved eligibility from here to there, and we have an opportunity to actually turn this epidemic around without any further discussion. So let's just forget about those issues. That discussion is going to continue in the background. But let's, instead of focusing on our differences, let's focus on the areas of common agreement and say, okay, we agree that we need to offer treatment to all of the people below 500 and the serodiscordant couples and co-infected hepatitis B and TB and children under 5 and pregnant women for life. This is fantastic. I mean, I tell you, all the years we've been talking about moving this forward, I feel that from a normative perspective, we are there. The next step is we need to recruit all of those young, committed, budding investigators to work with us to do the very difficult work of the implementation science.
Yes,
right, because now the difficult work is in front of us. The easy part is, believe it or not, is done. We did we documented the benefit at the individual level, at the community level, at the prevention level. We now transform that into a normative document. So we open the door for it. We need the money, that's for sure, but if we're going to make this work, we need the implementation science that is going to generate not only the best practices, guide the practices going forward, but also generate the efficiencies so that we can actually bring more people into the envelope with resources that are not going to expand proportionally to the number of people that we want to treat.
Yeah, and I think there's a lot of doctors that are activists. We talked about that. I think the doctors have to be activists. They have to be able to get themselves in front of the politicians, as you've done, for not only this, but the IDU and the needle exchange. I mean, these are all very serious issues, and the evidence is there.
Right.
We need to be operating now on the basis of evidence.
Well, you bring up a second very important point, and I think it's very clear that and this is a message for the young, budding, emerging sort of implementation science crowd that is out there that is going to join the fight. This is not just about doing the research and identifying what the best practices are. We need to take ownership of those findings or discoveries, and we need to be the effectors, the force that is going to make the public health system, the political system to embrace those new guidelines, as we've done for needle exchange, for supervised genocide, for early treatment, for treatment prevention, you name it. I mean, the roster is huge, but I think we need to send a clear message. We want you to help us to deliver on the promise of treatment and prevention under the framework of the WHO guidelines, which are going to dramatically increase eligibility, and they will continue to expand because the WHO is already talking about revisiting this document on an ongoing basis. But the point is, it's not just about doing the research and having a nice paper and then moving to the next one. It's to having the persistence and the strength and the leadership to make that into a reality.
Follow it through.
Right.
Yeah. So with all of this, I mean, you what will you be doing? I mean, I know that because you're going to be the model of I mean, you are the model of how to move through the process. Will you be talking about how to negotiate with some of the countries and?
Well, we've been intimately involved in trying to support colleagues around the world who want to embrace this way of thinking, to help them to push that envelope in their own districts. Some groups, academic groups, etc., they have a different way of operating. They set up satellites in this place, on the other place, or whatever. The way that I like to work is that my first commitment is to my own program. I want to be sure that I can do everything possible to ensure that our work in Vancouver and British Columbia can serve as a sort of a beacon of hope and show people that this can be done, of course, in a resource-rich environment. I want to apologize for that, but at least it gives a sense that it can be done. And then I like to work with colleagues, and I'm currently doing it throughout North America, in Africa, in Latin America, in China, and support them on translating the work that we've done. Of course, I'm extremely proud of the fact that Argentina, for example, was the first country in Latin America that embraced CD40500 for initiation of treatment, to a large extent because of the support that we gave to the program, the ministry, and of course my colleagues down there. But to be honest with you, the one example that I'm most proud of is the work that we've done with Dr. Sonyo Wu from the CDC in China, who he's very candid. I mean, when we first met to discuss this issue, he had one particular sort of view about what treatment and prevention was all about, and it didn't take more than a few months of ongoing interactions for him to become convinced that this was the way forward, and within less than a year, he actually mobilized the Chinese government to make treatment and prevention a pillar of the China strategy. I mean, and since then, he's done incredible work ramping up testing and ramping up access and changing the landscape so that hopefully in the future, in the not too distant future, China is going to start reporting on the huge improvements that they're seeing as well. In fact, they have already started seeing the benefits of it. So. What am I going to be doing? More of the same. I'm not giving up on this. The other thing that I think is important is that we recognize the lessons that we learn from the treatment and prevention campaign in HIV, which is something that, in all honesty, is an adaptation of what I learned from my dad from the tuberculosis field. Case finding, early intervention, supportive programs, et cetera, et cetera. But we have modernize them, if you want. If we could demonstrate that this approach applies to other areas such as hepatitis C or hepatitis B, sexually transmitted diseases, etc., there is so much overlap between those therapeutic areas and HIV that this would serve two purposes. And I've been very clear about this. I've been very clear with my own government about this. The first purpose is it will make my HIV success sustainable. Right. Because once you achieve success, it's very difficult to continue to invest on a problem that is no longer there. But yet we know that HIV is a dormant problem even after you have controlled it, if you ever control it. And so by bringing these other layers of therapeutic interest, if you want, it will strengthen my program. But at the same time, it will address a problem or several problems that are very dear to my patient population, which involve viral hepatitis, PNC, TB, STIs, and so on and so forth. So, and I think it's important because not only is good for my own backyard, which is the HIV backyard, if you want, but it is also revolutionary in terms of making healthcare more effective and more sustainable. At a time in which the dollars are limited, being able to bring something, a new way of doing business. I was saying we invest a little bit more up front here, but look at what we're doing. The burden of disease at the individual level, but at societal level, but at the public health level and at the fiscal level is also shrinking. We all win.
And put the people back to work.
Absolutely.
And have them a good life. The hepatitis C seems to be coming along very well, so that really is a good way to, like I say, put them all in that multi-level step. The other thing that I wanted to talk with you about, because we are going to be doing here in very short moments, in I guess an hour, a panel on young investigators. And I know that this is something that I like to talk to people like yourself about because the whole field is graying. We have to get more.
You mean the makeup is not working?
Yeah. You're looking good, I tell you. There's a lot. In fact, that's what most of the people that sit here now, they're getting older. They say, "Do I look good?" No, you're getting older. You can't do anything about it. But the idea is that we really do need to have that next generation, right. A really robust next generation of people who are really as committed as you. I don't know if that's possible.
Well, it is possible. I'm very, very fortunate. In my own group, we've been able to attract a tremendous number of young people who are, some of them not so young anymore, but then younger people behind them, that they are absolutely committed, smart, dedicated. It's just so energizing. And I think that I think people like myself, what we need to do is remain there to try to instill this sort of ethos, this way of doing business. The thing that differentiates a lot of people in my position from those in other areas of medicine, or some of them in HIV too, is that at one point in our life we realized that we had enough knowledge to really make a difference, and yet we were not being able to make a difference because that knowledge was not being applied optimally. And so we decided to become strong advocates for closing the implementation gap. To make the evidence available to those that need to make the decision so that they can make the right decision. But if they didn't make the right decision, to be there to tell them that you have not made the right decision.
And thank them when they do.
Of course. Yes. Thank them vocally and profusely because they deserve that. But at the same time, we cannot be too shy in criticizing them if they don't. Some people from other ways of thinking, they have told me repeatedly, well, you have crossed the line, you have become too much of an advocate. I consider that a compliment.
Right.
Because if it wasn't because of that level of advocacy, we wouldn't be where we are today. And we're not far enough, but I tell you, we are heading in the right direction.
I thank you so much for being here and doing this again for me.
Thank you.